bring me something that saves me time, that makes me more money, and I'll happily invest my time and money in it. This would not have made sense if not for COVID. The reality is we have the best healthcare in the world in America. It's just not evenly distributed. We need to really strategically think as a health system, how are we going to manage all of these patients? It is something that is much harder than selling a new piece of candy. We're getting cooler and cooler tech. It's getting cheaper and cheaper. AI is being adopted very fast in certain areas. We call ourselves a doctor happiness company. One of the most important things for a successful company is timing. Sad principle to make doctors happy and patients healthy. And that's how do you simplify, automate, and delegate routine, repeatable, rules-based care.
Welcome to our new episode of Digital Health Interviews. I'd like to remind you to subscribe to our channel and like this video if you actually enjoyed it, and I hope you will, because today we have an amazing guest. His name is Lyle Berkowitz. Lyle, please introduce yourself. Tell us a bit more about your amazing journey.
Well, I appreciate it. Alexei, I'm a physician, internal medicine primary care doc, who's always blended my career with seeing patients, doing health system executive work, and then being a digital health entrepreneur before we were even calling it that. So since the mid-90s. And over the years, I've sort of shifted less clinical care, more executive work, and then more digital health work till now. I'm a full-time digital health entrepreneur running a big national telehealth company.
So you've been in healthcare for almost 30 years?
Yes, at least.
I assume healthcare changed a lot over the past 30 years. Can you tell us, like, the changes that happened, were they more positive or we face more challenges with those changes?
A little of everything, right? We've seen some financial reimbursement shifting, but not huge. Like, we were actually more capitated, value-based care in the early and mid-90s, and that sort of went away. And now, it's a continued blend of fee-for-service and value-based care. Obviously, the biggest changes were in electronic medical records and IT, and yet, in many ways, doctors still feel, busier than ever. Because what happens is that with the reimbursement changes often comes documentation changes. And what we sometimes don't recognize is that documentation requirements went up. And electronic medical records allowed us to do that. But a lot of doctors blamed electronic medical records, saying, I've got to spend so much more time documenting. It's not the EMR's fault as much as it is the reimbursement mechanisms that require more documentation. And in fact, the level of documentation required would be impossible if we were all just paper-based in many ways. So, and because of EMRs, it's laid the groundwork for the ability to really do better at population health, value-based care, et cetera, if we can get back to reimbursing that way. So I'd say on top of that, of course, just an explosion of medical knowledge, more diseases, more tests, more medications, more treatments, and how do we manage and maintain all of those? Again, the EMRs, as difficult as they feel sometimes, allow us to manage all this stuff that if we had to go back on paper, would be very hard to do in a regimented way. So overall, like a lot of things, some feels different, some feels the same. What the biggest frustration is we're dealing with worse and worse access issues to get to a doctor, and simply not enough time to take care of everybody the way we should. But part of that is borne by the way we pay doctors, and so I think some of the biggest changes that have to come may have to be more about reimbursement. The technology is here to do a lot of really cool stuff. But we have to figure out how to pay doctors right, and we have to set the culture right on how much we can automate, how much we can delegate, how much the doctor should be doing themselves, how much the technology can do for them.
So you mentioned value-based care. What's your personal take? There's so much going on in this space, and people are like, yes, let's switch from fee-for-service model to value-based care. and yet there are not that many successful companies in the space. What's your take on value-based care right now?
Well, one of the problems we have as a country, we can easily point to the fact that we spend more per capita than almost any other country, and our results across the board are worse, or I should say, on average are worse. The reality is we have the best healthcare in the world in America. It's just not evenly distributed. And one of our biggest problems is not as simple as saying, oh, we have fee-for-service and we don't have value-based care. One of the fundamental problems we have is that we don't have a consistent payment mechanism. Germany uses employer-based fee-for-service type of care and is able to have good outcomes. And there may be some value-based care in it, but it's a single payer. In our country, we have multiple payers. We have the government paying for Medicare, Medicaid, VA, and government employees. We have private employers, and employers paying for a lot of insurance. And we have fee-for-service, value-based care. It's all mixed around. And so it's hard to optimize something that isn't consistent. And so the real question or issue is not as simple as, can we just all do value-based care, do more of it? We have to commit. Most places will tell you you have to get to at least 50% of your patients having value-based care to have an optimized system around that. And so you can't just say, oh, we'll just do value-based care with a couple folks. But in the big sense of things, the more we can pay for what we want, the more we align incentives around value rather than volume. Everyone acknowledges that's better. But our system, is is set up such that it's very hard to make those changes because a lot of organizations are really well optimized around fee-for-service. And if they're well optimized around that, they've got no major reason to change, particularly if it moved to value-based care in a way that is not consistent enough that they'd lose money on.
You mentioned in the beginning of your answer about the expenses for healthcare in the US. And I believe in 2025 is going to be exceed $5 trillion. And I want to kind of shift our conversation more towards technology. So a lot of startup founders, when they pitch their ideas, they say either we're going to reduce cost or improve quality. And with the raise of money United States spend on healthcare, why do you think we don't see actual cost reduction? Or should we even talk about this correlation between expenses of the whole country with the technology that is being adopted?
So there's a great book that was written in the 90s called The New Thing. And so in it, right, it follows Jim Clark as someone who's been very successful in Silicon Valley trying to create a digital health company. And he says, well, it's simple. In the regular industry, you've got a buyer and a seller. In healthcare, you just have three entities. You have the patient, the provider, and the payer. And we just have to connect those three. But the problem is going from a two-sided system to a three-sided system is incredibly complex because the incentives aren't aligned. When I was the head of innovation at Northwestern Medicine here in Chicago, part of my job was to take input from new companies and decide what innovative new companies could and should we work with. And I would always ask three questions. So if you're a digital health entrepreneur, be prepared for these three questions. Number one, who uses your product? Who has to spend any amount of time clicking, looking, doing anything, and physically has to use your product? Is it the doctor clicking on a keyboard, searching? Is it a nurse? Is it an administrator? Number two, who pays for your product? Is it the health system? Is it the payer, et cetera? And number three, who benefits financially from the use of your product? And what we'd often hear is someone would come in and say, oh, this is a wonderful product. If you use it on every patient, it will detect something in 1 in 100 patients, and it will decrease their chance of getting this disease or improving their life. So it improves quality and it cut costs. I'm like, well, who's it cut costs for? Oh, well, I guess the payer, the patient, I don't know. Who do you want to pay for it? Oh, well, you pay for it. I'm like, why would I pay for it if I don't get any financial value out of it? Well, it's the right thing to do. I'm like, well, that's all good, but that's not called aligned incentives. And we have this big problem, with entrepreneurs in healthcare. They're incredibly enthusiastic about how good their product is in helping something, but they don't take full account of how much time it might take a doctor, and the alignment with who pays for it. They'll often say, oh, it only takes a doctor an extra minute per patient. I'm like, well, I'm seeing 25 patients a day. One extra minute is almost half an hour. That's a lot of time, particularly if the value is only accrued to a small number of patients that I get no benefit from. Doctors are minute managers. Bring me something that saves me time, that makes me more money, and I'll happily invest my time and money in it. But bring me something that takes me more time and I see no financial value to doing it. Why would I use it? Just because some payer somewhere else makes more money by an ER diversion. So these are fundamental incentive alignments that startup founders need to understand acutely and when they're selling.
So if I understand correctly, you're saying that we do not see some major cost reduction because most of the times startup founders cannot find those incentives for all the sides?
It's difficult, and it's not just their fault. The system is set up such that you have to get the users, the doctors, to use and implement something in a world where they're in a health system that has a million projects going on. And you've got to convince them to do something that may take extra time. And then you also have to essentially convince someone else to pay for it for what might be downstream impact if these guys use it. So you have to, it's a chess game, right? It's not checkers. You have to do a lot of stuff. And intellectually, most digital health founders understand this, but to go in and convince a doctor to do it while I've got payers paying for it and they're willing to do it and create software that saves time, doesn't add time, there's a lot. It's not impossible, but it is something that is much harder than selling a new piece of candy.
What do we do? Just keep trying?
Well, there's a couple of things. I saw a good blog LinkedIn post recently about how often digital health startup founders focus on creating the perfect product, but should be focusing more on distribution, right? Because the problem is the product itself, if it isn't integrated into the fabric and easy to use, you'll never get distribution. It doesn't matter how pretty it looks. Doesn't matter how well it works if it was integrated. So when in 2010, I did a lecture at the Mayo Innovation Center at an annual conference. And I talked about the new wave of products and tools will be apps that sit on top of EMRs as a platform. This is before the EMRs did this. But eventually EMRs did come out with sort of their app store. And I built a company in anticipation of this called HealthTech, which basically said that we will help a doctor by taking work off of their plate and delegating it to someone else. I call it my SAD principle to make doctors happy and patients healthy. And that's how do you simplify, automate, and delegate routine, repeatable, rules-based care. In this case, we chose medication refills. So instead of creating a product that asked a doctor to spend one more minute, it actually took a minute off of a doctor's plate every time we used it. So instead of sending the doctor a medication refill request, asking them to think and then reply, we diverted it and we sent it to their staff using rules that the doctor had pre-approved. And so all of a sudden, we decreased the work on doctors and we increased the speed of which a refill request could be done. And to a doctor, that was valuable. I saved them half an hour a day. Health systems will pay for that because that doctor now is going to be happier, maybe can see another patient, et cetera. It's better care for the patient. We aligned incentives. We called ourselves a doctor happiness company because it was all about how do we take work off of the doctor's plate, not add to it. And we used the distribution model of being an app in EMRs, and we became one of the first apps in Athena and Allscripts and Epic and Cerner, and started even winning awards for best app because we were ahead of the game. We got fortunate that we developed the product at the same time the EMRs were starting to develop their app stores, and it all congealed at the same time because, like it or not, one of the most important things for a successful company is timing, and that worked out well for us.
Very interesting. Now you're a founder and CEO of KeyCare. Tell us more about it.
So KeyCare is a national medical group, and we are all virtual. So it's really one of the nation's first truly all virtual national medical groups, set up differently than some of the other telehealth companies in that we are on a fully robust version of Epic and meaningful use EMR that integrates automatically with all the other Epic systems, which is 60-70% of healthcare, right, is on Epic in some form or fashion. So we focused on, let's get the distribution figured out from the get-go. Let's use the operating system that is used by so many other health systems. And so then we can go and partner with those health systems in a very coordinated way. So if they need extra support for urgent care, preventive care, chronic care, we have a virtualist workforce that is on a telehealth optimized version of Epic. So we don't sell technology, we simply offer access to a nationwide panel of doctors who are specialized in doing virtual care and specialized in doing this in coordination to co-manage patients with what we'll call the office-based doctors or officeologists that are in the health systems using Epic.
Few clarifications. Does that mean, and I agree, 70% of the market is definitely a huge market, but are you planning to work with other EHRs at some point?
So I'm certainly not getting another version of any other EMR to do this on. We can theoretically work with anyone else. They don't have to have an EMR. If they have another EMR, we can use, there's obviously standard national interoperability standards like care quality, TEFCA coming out, et cetera. So we can always work with them that way. But Epic has a uniquely amazing interoperability functionality. They call it Care Everywhere, which allows for data to be fully shared between any two Epic instances. Additionally, they've come out with what I call workflow interoperability, tools that allow for cross-instance scheduling. They can do cross-instance messaging, we can do orders, et cetera. So all of a sudden, we can be a scalable support model for multiple different health systems, while we can optimize our Epic instance around being the best and fastest at virtual care. Whereas the health system, they've got a lot of things to worry about optimizing their Epic instance. We can focus exclusively and laser vision on how our Epic instance is fine-tuned to just take care of virtual patients.
Would you consider some of the major telehealth providers your competitors? Because I assume they also integrate with Epic at some point.
So they, of course, competitors in the sense of they can deliver telehealth as well. Most health systems find that they just aren't adequate for their needs because it's very much done in a siloed where the sharing is not nearly as coordinated. It's a much smaller amount of data. It's often not in the same format. It's not stored in the same place, and it's not bidirectional, right? Where when I see a patient, I can look at past years of data, and that's important. Being able to look at their last ER visit, their last CAT scan or labs, their last note, their up-to-date allergy and medication list. These things are really important, whether it's for a mild urgent care problem or a more sophisticated issue. And vice versa, when we're done, when we send the data back, it's sent in a fully coordinated way. So number one is the sharing of the data is much more complete and elegant and seamless. And that's important not only for efficiency, but also for quality. And a better patient experience. Like patients don't want to have to answer again their past history. They love knowing that the doctor they're seeing actually knows who they are and what their history is. Additionally, we have Epic. Epic is by far, the most, it's a meaningful use EMR. Most telehealth companies do not have a fully functional EMR. They just have a transactional system that they've homegrown. Epic meets all the meaningful use criteria. Also, Epic spends $1-2 billion a year on R&D. Right? They're constantly making it better. It is consistently wins class and other evaluations as the best EMR out there. It's not perfect, no EMR is, but I feel really good that I've got a partner who's constantly making it better in terms of sharing data, but also in terms of how it's used. They're improving basic documentation, they're improving population health, telehealth functionality. Every couple of months, new stuff comes rolling out. They're rolling out tons and tons of AI services and tools, et cetera, that's built into the system. On top of that, I've got a whole ecosystem of digital health companies building stuff for Epic because it's the biggest operating system out there. And so I benefit both from what Epic builds, but also from what external companies are building. And finally, we have a really talented organization that is helping us modify and improve our own Epic instance in a variety of ways. So it's, again, different and better for virtual care than I think any other Epic instance out there.
You started the company 3.5 years ago or something like that?
Well, yeah, we started talking about it, in late 21, but we really leaned into it. In 2022 is when we started building out our instance, and we went live essentially in 2023.
So was the idea born because you were in the epicenter of pandemic, or you had this idea a long time?
This would not have made sense if not for COVID, because a couple things changed. One, all of a sudden, everybody was much more comfortable with telehealth, and particularly the health systems. I had previously worked at another telehealth vendor, right? After 20 plus years at an academic medical center, Northwestern, I worked for MD Live, one of the big telehealth vendors. And that was pre-COVID. And they worked more so with payers than anyone else and some employers. And it was good for that transactional care, keep people at the ER, particularly if they didn't have a doctor themselves. But the health systems were not really adopting telehealth. And then overnight, because of COVID, they had to. And all of a sudden, all this innovation and thinking went quickly. They realized, oh my God, we can do 80% of healthcare online. And the doctors figured out how to do it. The tech people figured out how to do it. Patients were good with it. And for a short period of time, it was, 60, 70, 80% of healthcare was online. And then it went back. But the important thing on top of the cultural and technical push to make it happen is the insurance companies started paying for it. And that fundamentally is the critical thing here. And then by 2021, 2022, the volume of telehealth had gone down as people were coming back to the office. It's funny, some people say, oh, patients have been dying to get back to the office. That's not true, right? Patients actually love telehealth. Super convenient, easy, keeps them out of a room with a bunch of sick people. Study after study has shown about a third of patients prefer telehealth, particularly for routine issues. About a third just want to get in. They'll do either, whichever is fastest, which is most likely going to be telehealth. And a third really did like coming into the office. That's great, cool. Everyone should get to what they want. But what we're seeing is that a vast majority of folks are comfortable with, and some prefer doing everything as much as possible online. And so all of a sudden you had comfort level, you had a financial mechanism, and the technology had become a commodity, had become easier and easier to do. And it was embedded into Epic at this point. Pre-COVID, Epic was doing a little telehealth, but they weren't really spending as much time and energy because the health systems weren't asking for it. Post-COVID, they put a lot of time and energy into it, and so it's a very integrated approach. Although the video is a commodity, it doesn't really matter. I can do the video on some other system. I'm still documenting in Epic. Yes, it was born out of the fact that health systems recognized now they had greater need. They themselves were not experts at virtual care. Could a partner help them expand access in general and become experts at doing it virtually?
If I know the statistics correctly, I still believe right now, after all the boom went down, it's like 5% of all the claims for insurance are only virtual visits?
So it depends on how you look at it. I've seen, I'd say 5 to 10% would be on the lower end. Most health systems will say they're at 10 to 20%. Mm-hmm. And it also, you got to look at exactly what's being reimbursed versus what care is actually being done. So there may be a lot of care that's being done virtually that is post-op or not necessarily billed for. But I would say that the primary care and cerebral specialties are, in general, 10 to 20%. The surgical and procedural specialties are probably less than 10%, closer to 5% or even less for billable events, but they also will wind up doing some amount of post-op and post-procedure care virtually, but it's part of a global cap, so they don't bill for it, so you don't see that.
Telehealth appeared like in late 50s, so it's like almost 70 years. Do you think this percentage is high enough for all the work that's being done in basically digitizing healthcare delivery?
So pre-COVID, right, the health systems were using it, it's like under 0.5%. So, the fact is, we're at 10, 20, 30%, 300% more. So we've seen this huge increase, right? I mean, from these, or 10, 30, it's a huge increase. But no, I don't think we're done. I think that we need to really strategically think as a health system, how are we going to manage all of these patients? And again, what can we simplify? What can we automate? What can we delegate? And what can we virtualize? And I think that what we'll find is that as payment mechanisms evolve, that it will make more and more sense to outsource what we'll call the lower value care and take advantage of your office-based doctors by having them see the upper part of the pyramid that bring more value to your health system. I mean, my future as a primary care doc, I'd love to be able to tell other docs, hey, the good news is this. We're going to double your panel size and pay you accordingly, but we're going to do that by giving you a team that's online who's going to handle the routine stuff, and you're going to see the more complex stuff in the office, but you're only going to see 10 or 12 patients a day, not 25. And you're going to make a real difference in those people's lives. And if they say, well, I like seeing the easy stuff, well, if you want to be a virtualist, that's what they can see. But we're going to see, I think, an evolution of officeologists and virtualists. And it's not going to happen overnight. It's going to be gradual. But we are going to see some of that split. And this is population health and team-based care 101. It's just executable now that we have much easier virtual care and reimbursement mechanisms that will even explode more as we move towards more value-based care. And this concept is not brand new, right? Surgeons and dermatologists and dentists, they all use teams in various ways. Not really virtual, because they're proceduralist, all of them. And you don't have your top cardiothoracic surgeon saying, I'm closed to new patients, right? They expand their team. They're the rainmakers for the health system, bring more folks in. I think primary care docs should be treated similarly. If you're really good at what you do and you have a big practice, support that doctor by giving them more resources to work with. Because office space is limited and expensive, a lot of that team should be virtual. And my job is to make it super easy to scale that up, using a slightly different version of Epic, so to speak, that's optimized to do exactly that.
I love that. I'm personally a big fan of home-based care, and I'm excited about your optimism.
Yeah, we're. I mean, in many ways, we're just home-based care, right? We're going back to what it started. All care used to be in the home.
Right.
The important thing, besides technology, by the way, is we're recruiting what I call the new age virtualist. We're recruiting doctors who really buy into high-tech, online type of care, and it's just a different mindset. It's very hard to ask a doctor in the office, to go from a patient in the office to one online, and where you're treating things a little differently and need different tools. So I do see, similar to the hospitalist movement of the 90s, that we're going to see some divergence of those who are experts in hospital care, experts in office-based care, experts in virtual care, and that's okay. We've always seen these splits. My gosh, you look at cardiologists, used to just be cardiologists. Then it's invasive cardiologists and preventive cardiologists, and this guy only does AFib, et cetera. Nothing wrong with continuing to understand and and specialize a little even within primary care.
I mean, nowadays people would think the interview is fake if we not talk about AI even for a second.
Exactly.
So, like going back to our conversation about telehealth, and it took a while, like 70 years, to get to like that point that where we are right now. Do you think AI is going to be adopted much faster than that?
So, on one hand, yeah, AI is being adopted very fast in certain areas, right? I mean, it's probably in RCM and we don't even know it. I think the ambient AI technology to improve documentation is one of the fastest adoption curves I've ever seen by physicians, right? Because what happened, going back to our earlier conversation, one, it made life easier for doctors, right? Not harder. It somehow maybe saved them time or at least made things easier. And two, someone was willing to pay for it. In this case, the health systems did. Now, they assumed that it would save enough time that would pay for itself. The doctor would see 1 to 2 extra patients a day, and that it would bring in more revenue. That didn't actually happen. On the other hand, what happened is that doctors were happier with it, and the financial people said, well, we can live with the fact that happier doctors means that they'll retire less, they'll work more, and there's some financial savings we can justify. But we're not going to pay those top-end fees. So what we're seeing is that a lot of this AI is getting commoditized very quickly. Prices are coming down. Is it a race to the bottom on pricing? It's going to be in some cases. And the good news is, as a service provider, we all benefit. So as a doctor, we benefit. We're getting cooler and cooler tech. It's getting cheaper and cheaper. And the more that it can be used to somehow take work, again, simplify, automate, and delegate, the better. And I think AI has a better chance of doing that than some. My previous company, HealthTech, was rules-based. You can call that a form of AI, but it took, as long as it takes stuff off my plate, or doesn't add to my plate and make something better, there's a chance for it. So bottom line, AI is already being adopted, and it has the potential to be adopted more quickly. It also, I think, will be very interesting to see what the distribution channels are. Is it an app? Is it an add-on? How easily does it integrate into the system? That will become important because health systems don't like a lot of point solutions. They want everything just integrated because it's really hard to manage all these point solutions. And if one thing changes, one thing breaks, it can cause a lot of time and frustration and money to fix.
I agree. AI Scribe sounds very obvious solution for that solves specific problem. What other use cases are you really excited about?
Well, like I said, simplify, automate, delegate. So patient summaries, I think, will be interesting. Before the visit, I think anything, pre-visit data collection, et cetera. But I think in the end, there are 2 big important things that it can do. AI. One is it can improve the efficiency for the doctor, decrease the amount of time a doctor needs to spend with a patient, but still make sure the patient gets all the care they want. And that is automating in some way, the routine. The second bucket is it can detect difficult, rare, unusual things, needle in the haystack, and surface those up. So if bucket number 1 is make my life more efficient, bucket 2 is improve my quality by making sure I don't miss anything. Those seem to be the 2 big buckets that most doctors are going to say, I like it. I'll take either of those things. The issue is who's going to pay for it. Again, the health systems felt a little burned that they paid for this scribe, the AI scribe, and they're not seeing clear economic benefits. But the price is coming down so quickly, it's easier for them to justify. But each AI case will have to have its own use case and financial justification. But the good news is doctor happiness in a world where we're seeing burnout is enough of a justification in some cases. And improving quality to decrease malpractice, these are things that, they're different justifications than I think we initially thought there might be, but they're really important justifications. The CFO is starting to realize the doctors being happy, not quitting early is good. Less malpractice cases are good. Those 2 things can create financial incentives that align to pay for this.
over your career, you wore so many different hats: physician, chief medical officer, startup founder, entrepreneur in general, advisor, board member, investor, you name it. What is there a specific role you enjoy more than other?
Oh, interesting. I'm an adrenaline junkie, so I like to be thrown problems. I mean, probably, I'm an engineer by background, biomedical engineer, who early on in my life and career, I said, I read an article that said, find something, have a goal in life that is probably impossible to achieve, so that way you'll never be bored. And mine was fixing healthcare, which is, lots of job security for all of us in healthcare. There's a lot to fix. And so I've enjoyed my evolution and changing. I've enjoyed balancing multiple roles. I mean, in the end, it's still all consistent. Everything I do is about making, life, better for doctors and better for patients at the same time. And making the healthcare system better, both micro and macro. And so to me, it's all consistent. I'm the same guy, just doing some aspect of a role. But yeah, I'm a firefighter. I'm a problem solver. I like, when there is a problem, a big meaty thing that I can fix. I actually get bored if everything's just going perfectly stable. But overall, I really like diving into clinical problems. As a startup founder, you got to raise money, deal with a lot of people, et cetera. It helps that I sort of have the vision over it all. It's probably, not, my biggest strength and alignment is going to be around solving those clinical problems, talking to patients and physicians, et cetera, not necessarily talking to the insurance companies per se, and yet I can talk to them better because I understand everything that has led up to that, and I understand how patients think, and how providers think, and how health systems think, and so it allows me to do everything and get to that ultimate goal of trying to do change at scale. It's really, I hate to say easy, but it's certainly easy to do certain things in a very small way. But to do it at scale, that's a real challenge. And that's what drives me these days.
Amazing. Finally, your last piece of advice for startup founders in digital health.
Don't do it. I've mentioned, certainly, it's the first piece of advice is probably don't do it. But if you're going to do it, right, make sure, this is classic, startup or innovation, you understand your end user. And when you understand someone, it's not simply asking them what their problem is or what they think the solution is. It's watching them, it's feeling them, it's exploring them, being an anthropologist. Don't just, ask a doctor, hey, if you have paper records, what would you want if it was electronic? Because they're just going to tell you, make it look like the paper records. You have to watch them, see how they document, see how they talk to patients, see how they do everything. Ask them how they feel, because you'll make a much better product that way if you understand truly on multiple levels your end user. And I'd pair that with figure out your distribution channel early on. Do not believe that if you make the best product, everything's going to come to you. It won't. You better spend as much time on that distribution channel as you do on that product.
I love that. Thank you so much, Lyle.
Okay, you bet. Thanks.